So I'm Courtney. Thank you for having me back again this year to talk about mental health. I'm going to start, let me get the clicker. So to start, just a little bit about me. So I was diagnosed with osteosarcoma in 2018. I was misdiagnosed for about 2.5 years. I was actually training for a marathon at the time, running 10 to 20 miles a day. I started getting a really dull pain in my hip. I figured that I had overworked it, I had an injury, whatever it may be. And my doctors felt like that was probably the same. I was diagnosed with sciatic pain multiple times. I was sent to physical therapy where I got a different diagnosis every single week. They did dry needling right into my tumor. After 2 years of begging and the pain getting a lot worse, I saw a new doctor who granted me an MRI. And of course, the MRI showed a large mass in my pelvis. Oops. I was in the middle of graduate school at the time to become a nurse practitioner, and that was kind of where I turned from underserved populations to working exclusively with cancer patients. I found throughout my journey that mental health was not a crucial piece. We spend a lot of time working on our therapies and our chemo, and we're so very grateful for our oncology team, but we just don't put a huge emphasis on everything else that goes on. So the importance of talking about mental health and cancer. So a few statistics I think are important to know. 33% of cancer patients experience mental health concerns throughout treatment. 25% of cancer survivors experience depression. 45% experience anxiety. We are at a 2 to 3 higher risk of suicide. And 19% higher death rate among cancer patients with untreated mental health concerns. Even with these statistics, only about 5% of patients receive care. And why might that be? That would be the stigma of mental health. Stigma of mental health is basically that we have a lack of understanding and mental health scares us. It's not a topic that we're willing to talk about. It's still very, very taboo. And it can make us feel misunderstood. It can cause isolation, and we feel like we can't talk to our family and friends about it. So I'm going to go through a couple of different potential diagnoses that you might see during cancer. This list is not exclusive, but it is just a brief overview. So first up would be major depressive disorder, or MDD. I'm sure we've all seen the commercials for antidepressants. Maybe we've had depression ourselves, our family members have had it. But typically what happens when we have a really down day is that day kind of stinks. Maybe we're crying or maybe we're really sad, but the next day we can kind of bounce back. That is not the case with major depression. This is a topic of day after day, we're feeling really down, we're feeling really sad, maybe we're crying a lot, we're isolating ourselves from other people. Our motivation is really low and our energy is really low. Those are two things that are hard to discern, but whether it's depression or it's chemo related, it's cancer related. But we can notice a change from our difference. If we have had low motivation the whole time and now it's like really, really tanked, then maybe there's something else going on. We can feel a lot of shame, blame, or guilt. So when we're depressed, maybe we're not up helping our kids. Maybe we're not able to get out of bed as much that day. Maybe we're not getting snacks. And we can feel a lot of guilt for feeling this way. We might feel hopeless that things are not going to get better. There's a lot of worthlessness. We feel really down about ourselves. Our self-esteem has gone down. We're saying a lot of negative things to ourselves. We can even have the suicidal thoughts. You can notice a lot of brain fog. Your concentration can be limited. Again, maybe we have a little chemo in there, so it can be a little hard to tell the difference. When we're depressed too, we can have moments where we do feel happy. We can have moments where we smile, but those are going to be pretty limited. We'll smile, we'll feel happy in that moment, and then that moment is over and we go back to feeling really down again. Depression can be increased when we don't have well control of our pain. That can definitely increase our likelihood to feel depressed. When we feel like we're a burden and we're lacking some of our independence that we once had. if we have a poor prognosis or very difficult treatments and certainly life-changing surgeries. And of course, the treatments themselves, chemo, some of our side effect medications, they can all have the side effect of causing depression. Then we move on to anxiety. There's a vast number of different types of anxiety between generalized anxiety, social anxiety, panic disorder. Today, I'm just gonna go over the basic, which is generalized anxiety disorder, or GAD. Anxiety is really the body's natural response to stress or fear. And it's truly an expected response. And if you do not feel any level of anxiety during cancer, I would be shocked. What really becomes the problem is when anxiety is overwhelming. It impacts our functioning, it changes our quality of life. It can feel very excessive and uncontrollable. You might notice feeling restless, very fatigued, lots of irritability or crankiness, and some sleep disturbance. Maybe our mind is just racing. We're going through all the potential thoughts at night and we can't sleep. Anxiety before treatments has been correlated to an increased amount of nausea and vomiting and pain. Anxiety for some people can delay treatments. Now, some special stressors that we experience in cancer, first up would be scanxiety. I'm sure almost all of us who've had cancer experience scanxiety, or our caregivers and everyone around us. Any time leading up to a scan is terrifying. We don't know what we're gonna find. We don't know what we're gonna see. Is our cancer back? Has it spread? It's terrifying. And we can feel a lot of heightened anxiety, maybe a month leading up to it, a week leading up to it. And even after we've done it, we're waiting for those results, of course. We can have a fear of recurrence and dying. Certainly our normal population of people who feel anxious do not have the same fears of dying that we do. The end of active treatment is huge. A lot of us aren't warned about what the end of active treatment feels like. We go from seeing our oncologist weekly or multiple times a week, seeing our whole care team, we're in the hospital, we're getting scans, to all of a sudden, we're done. And that is terrifying. You go and you're home and you're like, okay, we'll see you in 3 months. And it's scary and it causes a lot of anxiety for a lot of people, and I would be one of them. Certainly anniversaries, when we're coming up on the day we were first diagnosed, the day we ended treatment, certainly when people have passed away, and anticipation in general, whether it's anticipation for going back to starting care again, anticipating if we're gonna have to change our goals, just that anticipation in general can cause a lot of anxiety. Oh, I didn't touch on panic attacks, sorry. Panic attacks are a huge piece of anxiety as well. Panic feels like a surge of anxiety that comes on very, very quickly. It can happen in a moment of seconds. It can happen completely out of the blue, where we're just doing our normal day lives and all of a sudden this panic just rushes in. Or it can be that we're already super anxious and now that's just reached a whole new level. Panic can feel like our chest is really, really tight, an elephant's sitting on it. We're feeling short of breath, we're dizzy, we feel out of body, nauseous. It can come with a wide variety of symptoms, and they can last from several minutes to up to an hour. My favorite topic with cancer is PTSD. A lot of times we think about trauma from war veterans, kids who have been through very harsh experiences in childhood, but cancer patients also experience trauma. Cancer is not fun, it's extremely hard, and it puts a lot of strain on our body. PTSD can feel like you have nightmares. Every night, night after night, you're having nightmares about, maybe it's being in the hospital, treatment. Could be a wide variety of things that all relate to somehow your cancer. They can wake you up during the middle of the night. You can wake up feeling very panicked, sweaty. It can be hard to sleep, or you even fear going to sleep because you're worried you will have a nightmare. You can get flashbacks. At any random time, you can flash back to the first time you were diagnosed. I remember I've had flashbacks flashing back to sitting in the doctor's office, receiving that first notice of you have cancer. And I can remember every detail of that room and everything every single person said. And that can just come completely out of the blue. We can have intrusive thoughts That means a memory, a feeling, an emotion that just pops into your head when you're not expecting it. Maybe you're just watching TV and all of a sudden now we're thinking about cancer again. We can have a lot of avoidance where we avoid topics, places, things we used to enjoy that we now associate with cancer. I remember when I was in treatment, when I would feel good, I would want a specific type of coffee. I cannot drink that coffee anymore. Again, we come back to this guilt, shame, and blame. We feel shameful of how we're feeling. There's a lot of guilt put on ourselves that we have this kind of fear after cancer. Again, trouble sleeping. Of course, we're going back to talking about the nightmares. Trouble concentrating. We're in our head too much. We're thinking about a lot of other things, and we have a really hard time being grounded on our life. Hypervigilance. That essentially means that we are on edge. We're hyper aroused. We have a fear that something's coming. It keeps us kind of in that fight or flight sort of mode all the time. We can have a lot of anger, resentment, irritability. When we think about things that have happened to us, we may feel very angry. And of course, a loss of interest, things we might have enjoyed before. For me, I was a rock climber, I was a tennis player, I did a lot of active things, and of course, I have no interest in that now. PTSD is one that we don't talk about a lot in cancer, and it's one of the most important pieces that we need to cover. And then we'll talk about grief. So grief is a tricky little player. Grief and depression can look a little bit different. So when we're feeling grief, it's coming in waves. We have moments where we feel happy and we're enjoying things, and then we grieve for whatever that may be in that period of time. Our self-esteem generally is not affected though. We can still tend to enjoy life. We just feel a little bit of sadness to it. However, with depression, this is a pronounced level of sadness. This is sadness that is lasting every day, all day long. We're not seeing waves where it's just coming in and out. It's going to be there. With depression, again, we're having that really negative self-talk, poor self-esteem, feeling worthless and suicidal. But grief, I really want to make clear, is there's no right or wrong way to grieve. It all comes in different shapes and sizes. This is the sort of stages of grief that does not go in order in any way. You can start at bargaining. We're hoping, if we change this, our cancer will go away. If we eat healthy, our cancer will go away. Then maybe we slip into the depression again. We're feeling really, really sad. Then we're denying it. No, we don't have cancer. There's no way. They read those results wrong. There's absolutely no way. Then we can feel angry. Why did this happen to me? What did I do to deserve this? And then finally, we hopefully will reach a level of acceptance. This is what it is, and we're accepting it and figuring out how to move forward. But like I said, we don't have to go in this order. We can go back and forth as many times as we need to. The most important thing is, though, we have to deal with our grief. If we push grief down and we choose not to deal with it, it is going to rear its ugly head again, and it's going to be a lot harder. So I encourage you, however hard it is, that we have to figure out how to grieve. Like I said, there's no timeline. So this is just a brief overview of medication options. It's certainly not inclusive of every medicine option, but we're really trying to target a few couple selective neurotransmitters in the brain. That would be our serotonin, our norepinephrine, and dopamine. SSRIs stand for selective serotonin reuptake inhibitors. That includes some of our most popular ones that I listed there: Prozac, Celexa, Zoloft, Lexapro, Paxil. The SSRIs are usually our first pick for medicine if you haven't been on anything before. They're considered some of the more benign medicines in psychiatry, and they are first-line treatment for depression, anxiety, and trauma. Our SNRIs, that's where we're going to work a little bit on the norepinephrine instead of the serotonin. Norepinephrine is used for improved clarity. Norepinephrine works very well for anxiety. Some of those include Cymbalta, Effexor, Pristiq. Those are a little bit different in that our brain really, really likes norepinephrine, and we take these medicines, it attaches to our brain a little bit more. They can be harder to come off of, and that's one reason we just typically start with the SSRIs first, is because if we don't like them, we have side effects we need to change, it's a little bit easier to do that than with the SNRIs. But that does not mean that SNRIs do not work. They are fantastic. It's just, we're gonna take a little time to come off of them. The NDRI, the only class of medicine in that, is called Wellbutrin. Dopamine is responsible for giving us increased motivation, energy. When we have depression that feels really, really low, we're not interested in anything, our energy is very poor, we're having a hard time getting out of bed, Wellbutrin can be a good pick for that because it's essentially going to give you a boost. So then we have our anxiolytics, which are used for anxiety. Those, I listed a couple of different classifications of meds there. We have Buspar, hydroxyzine. I can't read my own stuff. Then we've got the benzodiazepines. I listed several options of those, which include Ativan, Clonidine, Klonopin, Xanax, and Valium. Benzodiazepines are essentially supposed to be used for a short term. They can be used when we're having moments of panic. They can also be used when we're starting on an SSRI because those are going to take a few weeks to build up. Benzos are not supposed to be used for long term, and we can develop dependence on them. We also have gabapentin and propranolol. Then the last two I listed there are clonidine and prazosin. They can be used for anxiety, but they are also used corely for PTSD. Prazosin can reduce nightmares, intrusive thoughts, and hypervigilance. And then we have some mood stabilizers, some antipsychotics. The first up is Abilify. We've got Seroquel, Lamictal, Topamax, and lithium. That is not an exclusive list, but sometimes we have to add a mood stabilizer to an antidepressant to see that full picture of coverage. And then talking about OTCs and supplements, those are not well regulated by the FDA, so you should check with your provider before you add anything onto your regimen. A couple of things about meds though is it's going to take about 3 to 5 weeks for antidepressants to work. So please don't give up on them if you're not seeing results in the first week. We're typically going to start at a lower dose. We want to build that dose up slowly, and our goal is to keep you on the lowest dose possible for efficacy. So it may be that we start you on a lower dose and we're going to have to build it up over time. You do need to take your medicine every day. If you're skipping doses, it's going to be very hard for us to feel if this is a good option for you because it may just be we don't have a high enough level of the medicine in your system. Do not stop the medicines cold turkey. If you don't like them, if you're having side effects, they're not helping, please just talk to your doctor. We want to hear from you. We want to make those decisions. We want to change it if you don't like it, but we just really don't want you to stop it cold turkey. And more importantly, it can take more than one med trial to find out what's going to work for you. And I know that's a really unfortunate thing about psychiatry is it's very black. It's not black and white. It's gray. It's very, very gray. One medicine that works for one person may do absolutely nothing for the next. So you do have to bear with us while we do try some med trials. But after we tried that first one, we see how you respond and it gives us a better idea of where we're going to go to next. So getting help. Medicine is certainly a good piece of treating mental health, but therapy is extremely important. When we do medicine and therapy together, that is where we see that 100% improvement. If I do medicine alone, I'm looking at 40 to 60% improvement. If we do therapy, we're looking at 40 to 60% improvement. If we do these together, that is the more likelihood that you're going to feel better. Some sources where you can get help. So first up is psycho-oncology. Psycho-oncology is a cancer specialty that addresses psychological, behavior, emotion, and social issues that cancer patients and their families. Palliative care. Palliative care has a huge misconception that this is hospice. It's not so much hospice. It's specialized care for people living with a serious illness that aims at optimizing our quality of life and reducing suffering. Palliative care can address side effects from medication, treatments. They can help with pain management and a lot more. Oncology social workers can provide counseling, case management, support groups. They can help with locating services. They can assist you with things like applying for Social Security, disability, financial assistance, grants, and transportation. Counseling offers us strategies at teaching us how to live with the unchangeable realities of cancer, helping to manage the fears and anxiety and depression, helps us manage the fear of recurrence. A couple of the different therapies I listed there, first up is CBT. That is cognitive behavioral therapy. That's where we're becoming aware of our negative thinking so that we can respond to these situations more efficiently. DBT is dialectical behavioral therapy, and that does use some pieces of CBT in it, but we focus a lot on mindfulness, distress tolerance. We're talking about some interpersonal struggles that we can have between ourselves, and emotional regulation. And then EMDR, eye movement desensitization and reprocessing. EMDR is considered the gold standard for trauma treatment. If you have a diagnosis of PTSD and you've gone through CBT and you're not seeing much improvement, I highly encourage you to find an EMDR specialist. For kiddos, we can do play therapy. We can add in some art therapy. Certainly art therapy can be for adults too. And animal therapy, working with equine, dogs, cats, has shown huge improvement in mental health. And then I highly encourage you, when we're finding a counselor, to find a counselor that has experience in cancer. This is someone that will understand both our medical side and the psychological side that impacts cancer. Coping skills. We hear this, well, I hear this term thrown around a lot. So what really are coping skills? These are things that we do to manage stressful situations. We can have really great coping skills, or we can have some really, really poor coping skills. But our goal is to help improve our mood and anxiety. Really, everyone's coping skills are going to be different. Things we can think about are aromatherapy, warm baths. We might choose to learn a new hobby during cancer. Some of the hobbies we used to do, we no longer can do. Some things include knitting, bird watching, reading, blogging even. Learning to color, paint, scrapbook. I know a lot of patients talk about the adult coloring books, and that is one thing I used during cancer when I was in the hospital. Talking to a friend, going out for a cup of tea, definitely exercising as tolerated. Exercise has shown huge improvement with mental health in general. Getting out of the house, even if you're tired that day, maybe just as far as you can go. Take a walk down, just like you were saying, take a walk down to the mailbox. Do whatever you can. It doesn't have to be a marathon. It doesn't have to be anything huge, but those small steps really do make you feel better. We can also think about some mindfulness, grounding techniques, deep breathing, meditation. Not all of these things are going to work for all of us, but it's certainly things we can try. Now, the thing with coping skills is you have to practice. I could teach you these coping skills all day long. We could do deep breathing together, but if you don't use these and practice them when you're feeling anxious, they're not going to help. And that's something I hear from patients a lot, is that, oh, that doesn't help me. Oh, that doesn't work. But we have to try, and we really have to put in the effort to see if that's going to happen. If we do it one time and it doesn't help, that doesn't mean that it's not going to help in the future. Some things for stress reduction when we're thinking about cancer is we lose control during cancer. And that can be a really hard piece to let go of. Finding ways to feel control again is crucial. So find a new routine, find new structure, find things that you can control in life, because we can't control the cancer. We don't control our treatments. We lose a lot of that independence, but we can find subtle ways to still incorporate that into life. I've had patients tell me, just do what you can, admit what you can't. Support groups. So I know support groups are not for everyone. Sometimes when I suggest them, that's the first thing that goes down is, oh, I would never be comfortable in that. I encourage you to try. Support groups are huge for us, especially as sarcoma patients, and this is what we're founded on, is sarcoma is rare. This is not the same thing as we're gonna find when we walk into the grocery store and we can talk to 3 different breast cancer survivors. We need to coordinate with our people. And so if support groups scare you, oh, I don't feel like I can talk in front of people, I don't want to share my story, that's okay. You can go and you can just listen. And eventually, maybe you'll feel comfortable sharing what you have to say and sharing your story. Support groups can be online, they can be virtual, they can be in person. We have the great option of so much Zoom now where you take away those barriers. Maybe you don't have the transportation, maybe you're immune compromised. Well, we don't have that barrier anymore. We can get onto Zoom and we can still connect with people. I highly encourage caregivers to consider support groups. Consider support groups for your special population. There's support groups for In the middle of treatment, there's support groups for recovery. There's support groups for parents of kids who have cancer. Find the one that fits your niche. We have a lot more information on finding support groups and forming support groups on the Sarcoma Alliance website. And always ask at your hospital. There may be support groups that you don't even know of that they didn't mention to you, but if you ask, they might be there, or you might be the first one to start it, which would be amazing. All right, so humor. Laughing stimulates circulation and reduces tension in the muscles. For some people, laughing and humor is a coping skill, and sometimes it can just make light of stressful situations. I really found humor throughout my treatment to be crucial to me. That was one of my coping skills. I spent time taking way too many Snapchats with ridiculous filters. I got my nurses and my doctors and my whole team, every time I went in, they knew I was gonna take a picture. And those are honestly some of the greatest memories I have now. But the act of laughing can induce physical changes in the body. Let's see. Oh yeah, for me, one thing that kind of stuck with me throughout cancer is the day I was diagnosed, we named my tumor Tony the Tumor. And Tony the Tumor stuck with me this entire time. And he was kind of an ongoing joke for a long time. He's gone now, but he'll always live on. Now, toxic positivity, this is kind of an interesting topic. We can all say that cancer it pretty much just sucks. We all cope in our own ways. Some people find that being super positive, staying happy the whole time, that's what they need to do to get through cancer. But for some of us, that's not exactly what we want to hear. When I went through treatment every day, I was hearing, "You're so brave. You're a warrior. You're so strong. You look great bald. The shape of your head is beautiful. You are so young. There's no way you could have cancer." I can tell you, I got pretty tired of hearing some of these things. I didn't want to hear how brave I was. I didn't want to hear how strong I was. I just wanted to make it through the day. Toxic positivity is a term that describes an obsession with positive thinking and putting a positive spin on everything. You might feel the need to look less sick, smile more, or put on a fake face to make others more comfortable around you. You might need to wear a scarf to make them feel more comfortable. We can all have hope throughout cancer, but we don't all necessarily want to be happy-go-lucky the whole entire time. What can happen is it can be beneficial to communicate with others of what you need. I heard from my mom many, many times, "You are so brave, you're such a warrior," until I told her to please just stop. That's not what I wanted to hear anymore, and she respected that. People are just trying to help, honestly. When we hear these things, it's uncomfortable. Cancer is not a comfortable topic. We're not real comfortable talking about it. So it can be, those are the easy things to say, "Oh, you're so strong." And honestly, people are just trying to be kind to us. But it's important to help us understand what are our needs during cancer too. There's some days where you feel completely like crap. You don't want to smile, you don't feel strong, and you're just surviving the day. All of these feelings are valid during cancer. Whether you're feeling happy or you're feeling down that day, you are not required to feel a certain way. A touch on caregivers, which are hugely important to us as patients. Caregivers often put their own needs and feelings aside. They experience physical and psychological stressors just along with us. They can find a very hard time finding balance in their own life as they've taken on such new tasks for us. Important thing for caregivers to understand, it is also okay for them to ask for help. If you need more, if you don't feel like you can take care of the whole situation, it's okay to pass on the task of making dinner, to pass on the task of taking me to an appointment. You don't have to do it all. It's important to find a new routine. Your life has been shooken upside down just as ours has, and you need to find a new routine within that as well. You also need to develop your own coping skills and find self-care for yourself. Continue to attend your appointments, continue to take your medicines, see your doctors. My mom is a prime example. 2 months after I was finished treatment, my mom was diagnosed with cancer herself. She likely could have been diagnosed sooner if she had not been putting her entire focus on me. I encourage you to still take that time that you need to give to yourself. It's like just that, on the airplane, the mask thing, put your own mask on first and then put your mask on the person next to you. You got to do that as a caregiver also. It's important for caregivers to feel comfortable talking with their loved ones about emotions and feelings. This can help to reduce the stress of not knowing what to say all the time. You should also consider joining a support group, finding online groups geared towards caregivers. This can make you feel more connected and understand the role that you are in. Mental health in children. Nearly 50% of children with cancer struggle with mental health. 74% of family units are impacted, and children are at higher risk of long-term mental health struggles. While we see a lot of the same similar symptoms in children with depression and anxiety, there are a few things that point out a little bit differently. In children, we can see behavioral changes. Most often, we see an increase in irritability and anger. Depression and anxiety in children is almost always seen through irritability. You might find that they have less interest in things. Maybe they traditionally really love to play the Xbox, and that was a coping skill for them, and all of a sudden we're not wanting the Xbox anymore. We don't want to talk to our friends. We're isolating. Those can be clues. Increase in physical complaints. Crying. We can see in younger kids a huge amount of separation anxiety, and there's just a general fear of being alone. We also need to consider siblings. Siblings also go through a lot when their brother or sister is diagnosed with cancer. It's creating an increased stress on the entire family structure. They might feel less attention from parents. Difficulty managing school now and social settings feel much different for them. They have a level of anger and sadness. It's important to also help them find new routines. Make space for them, spend time with them as well. And always, again, support groups. And then our other special population is adolescent and young adults, or the AYA population, which is for patients that are ages 15 to 30 years old. Cancer is a little bit different for patients during this age group. AYAs experience unique challenges, but we're often grouped with other children or older patients. We can struggle with relationships, planning for college, playing sports. We worry about fertility and our future families. We worry about our marriages and our young children at home. We may experience large gaps in our work history and lost years in our specialties. We can lose a sense of identity, independence, and life milestones. AYAs are considered the most underserved population in cancer. They are often misdiagnosed or diagnosed much too late. It's important for AYAs to join together. I myself am an AYA and both a mother, wife, and professional. I found that support with people in the same spot in my life was crucial. It's a little bit different when you're first starting out and you have young children. Doesn't mean we're any better or any worse, but I found talking to other people who are similar in my age, they just understood a little bit differently. AYAs also really appreciate when people continue to act semi-normal around us. We don't want to seem weird. We don't want to seem like the cancer person. We want you to still treat us like a human and feel like we're semi-normal to you still. And then finally, suicide. So again, suicide is a taboo topic. It's not something we're very comfortable talking about. It can definitely be scary. Suicide, men have a higher risk of suicide as a whole, especially men during cancer. Patients over the age of 65 years are at increased risk. Poor prognosis is likely to have an increase in suicidal thoughts early in the treatment. Diagnosis of depression, anxiety, and trauma along the way increases our risk. There's a 13% higher risk of suicide in the first 3 months after diagnosis. Some of the warning signs we might see, again, increased isolation, sticking to ourselves, not coming out of our room, not talking, not engaging with anyone. We're giving possessions away, our prized jewelry, our prized arts. We're giving those to people so that we have a safe place for them. We're experiencing a lot of hopelessness. Maybe we're expressing that this is never going to go away. Nothing's ever going to get easier. And we're taking risky behaviors. We're doing things that are very out of character for us, and we don't seem to really care. What is suicidal ideation? So suicidal ideation, or SI, is a common term we hear, and it means it can be passive or active. Passive suicidal thoughts are essentially, I'm okay if I don't wake up tomorrow. If I walk out in the middle of the street and this car hits me, I'm okay with that. Active suicidal thoughts are when we're sitting there and we're planning, we're thinking about our ways, we have intent, we're writing our goodbye letters, we want to do this. When we think about active and passive suicidal thoughts, certainly I'm more worried if you're having active suicidal thoughts. Everyone is allowed to have passive suicidal thoughts, and it's a typical and it's a normal thing that most of us have experienced at least once in our lives. But when we move into that active phase, that's where we need to be very concerned. Do you have a plan? Do you know what that plan is? Do you have a day identified? Do you have a location identified? Do you have means to carry out your plan? Do you have maybe we want to have a plan to overdose on our medicine. Do we have access to all of that medicine? These are all things that I consider when I'm looking at how high is the risk for someone to complete suicide. During cancer, we can experience feelings of hopelessness. It's not uncommon to feel this during treatment and after treatment. Please do not feel ashamed of having these thoughts. They can be compounded by both physical and psychological factors. Please, please, please speak up. Talk to your family, talk to your friends, talk to your providers. That number I listed there at the bottom is a brand new number that just came out last week. 988 is now a national number that you can call if you're having suicidal thoughts. Similar to 911, you will be connected with a call center. There's over 200 of them throughout the country. If you need to talk to a counselor, you're feeling overwhelmed, you are feeling suicidal, no matter where you are, please call that number. And take care of your mental health. Any questions for me?
Any questions from the audience? I'll be right there with the mic.
Thanks. I was wondering if survivor's guilt was an issue, people who,
absolutely.
who are survivors and probably have known people who were not.
Absolutely. I think all of us, when we have this particular diagnosis, we see people around us that are passing away. We are living. We see people that are diagnosed before us that have passed, and there is a huge amount of survivor's guilt. It can bring on depression, anxiety, and it can also lead to more of those trauma-based thoughts. You know, I've had survivor's guilt myself, as several people that I was friends with during treatment passed away. And it's like, why am I still here? And why did they pass away? And it's tremendously hard on us, but it's also a way of taking this life that we have been granted and going with it, moving forward, figuring out how we can honor those that didn't make it and what that looks like for us. Does that answer your question? Yeah.
Thank you, Courtney. We've got a couple of questions as well on the online chat. The first one is, what coping skills would you recommend to navigate the medical system and optimize your treatment? Coloring books might not be the best option for this, but do you have any other suggestions?
I mean, there's tons and tons of coping skills. I highly encourage you to Google and look at, there's lists of coping skills everywhere that range from physical activities to mental activities. You know, we can all focus on mindfulness. Mindfulness is essentially trying to be present in today. It's not thinking about tomorrow. It's not thinking about yesterday. It's staying in this very moment right now. And that can help reduce the fears. There's so many different coping skills we could try. There's deep breathing. There's one that a lot of people like to use where we think about a square. So we've got this box. We're starting in this top part of the box and we're taking a breath in. We're holding this breath until we feel like we get to this other side of the box. Now we're letting our breath go and we're coming to the bottom of the box. Now we're breathing in and we're coming to the other side of the box. And now we're breathing out and we come to the top. And we can think of like this visualization when we're in a point of almost panic. We can take that time and we can visualize that box in our head, and you can go through it as many times as you need until you feel calmer.
Thank you. That was really helpful. There was another question. Somebody was wondering if the 988 number that you had mentioned is confidential.
I don't know that it is. I mean, it's confidential as like if you can call a crisis center. There is some crisis centers where we can track your number and your location, and that is for your own safety. I do know at certain locations, I mean, we do not have to, we're not required to provide our number. But if we're calling that, then it might be worth knowing where we are if we need that help right now and then.
Thank you. Randy?
Thank you. So I have a question. So after like treatment is over and it's done and your caretaker has been taking care of you, doing an amazing job, and then all of the burden is now finally, they're able to feel their feelings and not be the superhero anymore. So that happened with one of my caretakers, and they actually ended up trying to commit suicide. But what would be the way you could reach out to them or talk to them or help that person if they don't want to go get help and they're not expressing themselves? Like, how do you see the telling signs of that? Because had I not gone upstairs and saw that the person took all my medication and called 911, that person would have died.
So, I mean, even though our caregivers are not going through cancer, they're experiencing the same amount of mental health stuff that we are. They're feeling depressed, they're feeling anxious. Tons of our caregivers are also struggling with PTSD when we're done with this. It is very, very hard though when people do not want help and they do not want treatment. We can't often force them into it. You know, what's important is that I've found is continuing to have that open dialogue of mental health throughout your entire treatment, checking in on the people around you, like, hey, I know that I'm struggling, but how are you doing? Really encouraging our caregivers to hook up with other caregivers, join those support groups. Certainly it's very difficult though. I mean, we all run into it in our field that people don't want help. And unfortunately we can't force it unless they are at risk for suicide. I mean, it sounds like what you're saying, obviously it's very concerning, and they would seek, you know, inpatient psychiatric care at that point. But I think having that continued dialogue and like, really, let's just reduce the stigma. Why can't we just talk about this? We talk about our high blood pressure, we talk about diabetes, but when it comes to mental health, it's like, nope. If we continue to have those conversations, I think that would be where it's easier for us around each other to be like, hey, I'm not doing okay. Yeah.
Well, you kind of answered my question, but a little bit more, because I know after I went through, you know, the process, I wasn't forced to have to see a counselor, but it was pretty much encouraged for me to do so, and I was called and approached on it. So I just want to know, like, do you know how often that happens? Because when we talk about standard of care, I feel like that should be kind of a part of the standard of care too. That, you know, let's ask about their mental health, because that's also important, you know, like how you were saying.
For a lot of patients, from what I've heard and what I've talked to people about, mental health is not really considered that standard of care. You know, our standard of care when we're treating cancer is, as Gina and all of our amazing doctors have talked about today, is that traditional chemo treatment, surgery, etc. But when we're done, like I mentioned, like that end of care is really difficult because we are kind of just sent out on our own. It really depends on the facility and the providers if they highly encourage that. I know my provider, Dr. Villalobos, rolled over to me on my very last day that I saw him with my last scan, and he put his hands on my knees and he was like, it's going to get really hard now. And that was kind of my first indication that, what do you mean? Like, I just went through all of this. What do you mean? And I walked out of that office and I cried and cried and cried. And I wish that someone had told me at that time to go to therapy, but I was really hard-headed and I didn't think that I needed it. And I was a provider and I worked in mental health, and that was false. Am I good to go?
Thank you very much, Courtney.
Thank you.
That was great.
Thank you so much, Courtney. That was extremely important topic, something that we don't cover enough and don't provide support enough. We try to, as physicians, refer patients, and sometimes the insurance companies don't approve it. But there are resources out there. So if you are feeling on edge, or you can get the help that you need using other resources, and we can take appeals to insurance companies to get approvals. So, and we can, as oncologists, we can also provide you with medication if need be. So definitely talk to your doctor, let them know how you're feeling. And so thank you so much. That was so important of a topic.